And I would like to introduce our moderator today. Dr. Danetta Sloan is at the Johns Hopkins University Cambia Health Foundation Sojourn Scholar for 2019. She's also a consultant to the Center for Practical Bioethics on the Advanced Care Planning and Healthy Living Through Faith project, and a member of the African American Advanced Care Planning Network. Danetta, you can take it away. Oh, I think you're still on mute.
Hi, and good morning and good afternoon to everyone on the webinar, and thank you for joining us today. I really want to introduce our panel now. I first would like to introduce Reverend Cynthia Carter Perrilliat. Reverend Perrilliat has over 25 years of experience as a change agent in healthcare, marketing and communication, biotechnologies, and community organizations. And specifically over the last 15 years, she's focused on end-of-life care program development and educational training in African Americans, Latinx, and Asian communities. As a part of VITAS Healthcare, Reverend Cynthia established a targeted compassionate care approach to communities of color, which are adopted and replicated across 17-state footprint of the 17-state footprint of VITAS. She's also served as faculty member of the Duke University Appeal Program, a palliative care educational curriculum for African Americans at the end of life. Welcome, Reverend Perrilliat. We also have Dr. Jill Joseph, who's trained in both public health and in medicine. Dr. Joseph has been conducting research for decades designed to achieve health equity, often with a special focus on vulnerable families. She also led large multi-million-dollar programs in research and mentored junior faculty. And for the past 5 years, she has consulted to and collaborated with the Alameda County Care Alliance Collaborative, with responsibility for the design of the intervention and training of the Care Navigators. And let me please make a correction. I completely left off that Reverend Perrilliat is a part of the African American Advanced Care Planning Network, and is also a member of the African American Advanced Care Planning Network that is a part of the center's effort, and one of the founding members of the Alameda County Care Alliance Collaborative with Dr. Joseph. So I did leave that off, and I do apologize for that. Next, I would like to welcome Reverend Dr. Jacqueline A. Thompson, who is a senior pastor for the Allen Temple Baptist Church. Dr. Thompson is the pastor of Allen Temple Baptist Church, which is a founding congregation of the Alameda County Care Alliance Collaborative. And I may refer to that as the ACCA moving forward. That's a mouthful. But she has a desire to help people alleviate the condition that seems to keep people disenfranchised. She graduated from the University of California, Berkeley, where she majored in political economy of industrial societies, at which time she then directed her journey towards God's purpose for her life and attended Howard University School of Divinity. In keeping with the ministry of First, God has given her, in March 10th, she was installed as the assistant pastor at the Allen Temple Baptist Church, and in December 2019, she was installed as the senior pastor at Allen Temple Baptist Church. And then last but not least, Pastor Horacio Jones, welcome. Thank you for joining us today. Pastor Jones is the senior pastor of the Family Bible Fellowship of Newark, California. His church is also a founding congregation of the Alameda County Care Alliance Collaborative, ACCA. And Pastor Jones serves on its pastoral advisory committee. Pastor Jones established the Tri-Cities Community Development Center in 1997. The center provides services, programs, and resources for, in his words, the least of our society. He currently, as president and CEO, manages reentry services for ex-offenders. And that may encompass, or does encompass, mental health training and advocacy for the African American community, and academic development for children struggling to excel in the classroom. Pastor Jones is actively engaged in eliminating stigma and discrimination related with living with a mental illness, a mental health diagnosis. And as a recipient of an innovation grant from the Alameda County Behavioral Health Care Services, Pastor Jones developed mental health friendly congregations. Pastor Jones believes that the work of the Black church historically and contemporarily has served as a foundation for hope, change, and empowerment for the African American community. I welcome all of our panelists today, and really want to thank you and appreciate your time today. And I would like to turn it over to Reverend Perrilliat, who's going to share with us a few slides in reference to her faith-based Care Navigators program, which is a program to promote the well-being of individuals with serious illness and their caregivers. Tell us more, please.
Thank you so very much, Dr. Sloan. It's a pleasure to be here. We're really excited for this great opportunity to share with you and, of course, the wonderful work of the Center for Bioethics. And I have to tell you, I am the fortunate one today. I get the chance to be present with all of you and these wonderful fellow panelists who I have just the wonderful privilege to work with on a regular basis. It's exciting for us to share the model of the ACCA, the Alameda County Care Alliance Collaborative. And our focus today and the topic really is heavily on our Care Navigators. These are faith-based Care Navigators, and the work of the Navigator is to really support the well-being of individuals that have advanced illness needs, but also their beloved caregivers. So a little bit of background about the Alameda County Care Alliance Collaborative, and you'll notice the word collaborative is tremendously important because today we have the opportunity to share with this wonderful national audience that literally our organization has heavily focused our work within the Alameda County, the Contra Costa County areas of Northern California. We're excited to announce that we're expanding to the San Francisco County, and also this opportunity allows us to share with the national audience the incredible work that we have been so blessed and fortunate and privileged, frankly, to engage in over these 7 years. So the ACCA model and vision really seeks to increase and build infrastructure from the health systems to the community, and from the community to health systems. So what are we saying there? We often think about our loved ones, family members, members in the community and congregations that are dealing with health challenges, advanced illness, even end of life, if you will. Many times those loved ones find themselves in the hospitals or in nursing facilities, but this collaboration seeks to bridge the gaps from the actual admission in the hospital health systems, but also when they are returning home, where does the support come from? How do they get their needs met? Many times individuals feel, if I can be honest, sometimes really abandoned. if they don't have strong family support. And even when they do, family members often are left adrift in terms of knowing just what we do. How do we best care for our loved ones? So again, this model seeks to build infrastructure from the health system to the community and from the community to the health system. I'm excited about the fact that this work was born, bred, and developed in the African American faith-based community. And we're tremendously proud of the fact that we've been able to engage just the depth and the breadth of wonderful leadership, like my pastor, I should tell you, Dr. Jacqueline A. Thompson, who is the pastor of Allen Temple Baptist Church. You'll be hearing more from Dr. Thompson. And also Pastor Horacio Jones, who's also been with us from the very beginning of this work. And I have to tell you, our pastors really wanted to not only support the holistic needs of their congregants and the community as a whole, but we wanted to be very intentional about addressing the health disparities, the racial disparities that we see in our communities of color, particularly the African American community, the Latino communities. And we're going to talk more about the importance of this model so that while we have developed, birthed this incredible model, our desire is to spread this throughout communities. And so we're going to talk about health equity and advancing equity, but we're also going to talk about the importance and the resilience of community so that they can take this model, tweak it, and so it can fit based upon their own holistic concepts. I'd like to just really quickly focus on a very busy slide here, but we wanted to really set some context for what we refer to as a true person-centered approach to care. We hear in our health systems often how important it is to focus on what the individual, many times we use the terms patients, we refer to individuals as persons needing care because we believe language and how we use language is so important in how we refer to our members and our family members and people in the community that need advanced illness care support. And so our goal is that every human being that is dealing with serious chronic illnesses and their caregivers receive the holistic care that aligns with their wishes, not the wishes of the health system, but the wishes of the individual. So how do we do that? Goal setting is tremendously important. So our trained, wonderful care navigators, these individuals are well-respected, trusted individuals within the context of their own congregations and community. They listen. We have extensive training on storytelling, story listening, and therefore they have earned the trust. And we'll be talking a lot about trust in our conversation today, but trust is so very important to our participants having the sense that they're being heard and respected. And so goal setting is the work of the navigator, identifying the goals of participants. Again, that's both people that are dealing with advanced illness and their caregivers, and focusing on goals that are specific and achievable, again, that are important to the participant. In our program to date, about 77% of all visits really focus on what are the goals of the individual that has the advanced illness and or their caregiver. We find our navigators consistently speaking about this work as a calling for them. I've had folks all around the country to ask, how do you get your navigators to continue to work so successfully and intentionally in this work? And first and foremost, I have to say, to God be the glory, because we really believe that it is standing on what we have built on foundationally in the Black church for many years and caring for our own, and then responding to that from the perspective that this is an important work that God has called me to. This is certainly the perspective of our care navigators. And so again, trusted relationships, focusing on true person-centered care, that's really important for the individual that is dealing with advanced illness. I want to say one other thing, and then I'll pass the baton back to you. And I hope you don't mind me referring to you as Danetta, Dr. Sloan. The 5 cornerstone approach to care that we provide focuses on, number 1, spiritual. Again, I talked about the holistic needs of individuals. So spiritual, mental, and physical support are what this work is about. And so if an individual wants to pray, if they want to have their own particular meditative practices, if they have no interest in the spiritual, whatever that may be, we honor that. Again, person approach. The health focus is really all about helping them to identify what medications they're taking currently. We are not a medical model, but what we do is the Navigators work very closely with the participants to make sure those medicines and medications lists are listed and identified in the event that they have to go and re-enter, if you will, into the health system or a nursing facility, for example. That's just another example of the medical. It's really important that our participants are prepared when they see their primary care physician. And so our Navigators take the time. Of course, we're in COVID-19 shelter in place, so we're not having in-person visits, but we're also regularly in this particular period are having phone visits or virtual visits. And so we're preparing individuals for their doctor visits. As an example, what are the key concerns that you have, Mrs. Smith, as it relates to your health? Are you prepared? And can I assist you as a navigator to identify those questions so you really get to what it is you want when you speak with your primary care physician? Social needs are one of the other of the 5 cornerstones. As you can imagine, food resources, transportation, to the doctor's office. Again, we're still seeing some of that need even in this COVID-19 period. Issues around really housing. It's really sad to say that some of our seniors are losing their housing in this very vulnerable time in their lives. Our Navigators assist them with registering and doing the necessary details around housing. Advanced care planning is really one that, and we're proud of all of these, but we're going to show you later some strong statistics that speak to how this Care Navigator faith-based model is making a difference with individuals literally identifying a healthcare agent, but also ultimately filling out that important paperwork around advanced care planning. And last but not least of our 5 cornerstones is the caregiver support needs. Caregivers, God bless them. Having been one myself for my father and my brother, caregiving is a very difficult job. A lot of the work that we do is to give that caregiver the opportunity to voice, express their needs, again, from a holistic perspective. And then we literally work with them through our caregiver workbook. We also are going to talk about that caregiver workbook. And I failed to mention on advanced care planning, we work with our participants through our care planning workbook, and you'll get a chance to see that as we progress further. But tools, training, empowerment of our participants within this pretty much 6-month period that we're working with them, so that in the event that they no longer need our services within the 6-month time frame, they will have important and each of these 5 cornerstones that literally they can refer back and forth to if they would like to. And the last thing I'll say about our true person-centered care approach through this 5 cornerstones of care is that we really deal with the notion, frankly, of care and love. How can we connect with people so that they know in this very challenging and vulnerable time in their lives, they are loved?
Thank you. Thank you. And yes, you may call me Danetta. I don't mind.
You can call me Cynthia.
Okay, Cynthia. Don't mind that at all. Before we pause and really have conversation, I really would like to move to Dr. Jill Joseph. She is going to talk a little bit about the successes of the program and give us a little bit more information. Is that okay that we do that now, Dr. Joseph? Okay, all right, Jill.
When I came into the world, I was just Jill, and when I transition, I'll be just Jill, and in between, it's fine. Thank you so much, Matt. Let me begin by saying that I'm part of the University of California, Davis, And there is an important colleague there, Dr. Janice Bell, who is also just Janice, who is not on the call today, but is responsible for one of the ways that we collaborate and work with Reverend Cynthia and the team, and that is by providing evaluation. We understand how important it is that we have a sense of how the program is working, what its strengths are, so that we can talk to the community, so we can talk to pastors and explain its successes. So in addition to that collaboration through UC Davis, we also provide support for the development of the intervention and the training of the Care Navigators, as Reverend Cynthia has already mentioned. What we wanted to do on this slide was just review some of the successes that the program has experienced. Reverend Cynthia has already mentioned the fact that, for example, the Care Navigators view this frankly as a vocation, as a calling to service in their community, in their congregations. And I would suggest that right there, that's an important success. Another important success is demonstrated by this panel. You have Reverend Cynthia, you have pastors, you have myself. We have a consortium that has come together under the leadership of the ACCA leadership to bring this program into the community, into the lives of those who oftentimes have been neglected by the healthcare system, discriminated against, have experienced systemic racism, and come with some suspicion. So by being trusted members of the community, by being care navigators who are trained to bring, as Reverend Cynthia says, not just skills, but also compassion and love, we've been able to create this program. If we look at the program reach, first of all, what have we done? Since its inception, over 1,200 individuals who have needed care and their caregivers have received program services. So there's been a deep reach into the counties that we serve. There have been over 11,000 individuals who were touched by the program. And what do we mean by touched? Not everyone is going to enroll in the program. We think of it as a bullseye, that there are concentric circles of influence that spread out. And a care navigator may not work with someone for 6 months, may not deliver the intervention, but may meet with them and talk about advanced care planning. May talk with them, for example, about what a POLST is and how that can be arranged. May talk with them about what services are available in their church that they can link to. So these touches are a variety of ways that our care navigators reach even further into the community and into the lives of individuals there. 25 churches are now a part of the ACCAC in Alameda and Contra Costa counties. And I really have to recognize the hard work of Reverend Cynthia, the pastors who provide the leadership and guidance to the program in growing the program in a way so that more and more individuals and communities can participate in it. There are referral pathways and partnerships with health systems being established. This is important work. I'm a physician, I work clinically. We can only do so much. People don't live their lives in clinics and hospitals. Where they live them is in the community. So as Reverend Cynthia said in one of the first slides, we create bridges. We stand prepared to bring community resources, collaborating with clinicians in the care of their patients. And increasingly, health systems are turning to us, realizing their need for services such as this. How do we address participant needs? Well, there have been over 1,000 referrals to community services in the first program year, addressing 80% of stated needs. Quite frankly, I think everyone on this call understands the extent to which our systems, health systems, social service systems, are in many ways broken. Let's take a need for housing. There are seniors that we would like to get into senior housing, and the fact of the matter is that wait is years. We don't abandon them. We help them get on waiting lists, identify alternatives, continue to work with them even when a need that they have, because of the way that our cities and programs have been constructed, can't be met immediately. Typically, there are 4 to 6 resources identified for each participant using the visit extraction forms. Another success of the program is we now have gone entirely electronic. So this has to do with the work that was provided to over 200 persons needing care and their caregivers. Over 15 what we call tools have been developed by the program to help promote participant well-being. And what do we mean by a tool? Reverend Cynthia has already provided an example. Suppose that I'm a person needing care and I go, you know, I get to the doctor and I get so bamboozled, I can't think of what I want to say. I leave the office and 2 minutes later we're going, oh, good heavens, why didn't I tell her that I'm really frustrated with my medications? Well, we'll sit with that participant and we have a worksheet, something we call a tool. What is it you want to ask? What is it you really need to know in this visit? What are the questions you have? So the participant can come into that meeting and take charge and be empowered to deal with a healthcare provider. That's an example of a tool. We have another tool, 8 ways to feel better based on the research evidence. What is it that an individual who's having a hard day can do? Simple suggestions that we provide them. What's been the response to all this work? 1,200 people served, all these visits, all these resources. Well, we know that there's high participant satisfaction. On a scale from 1 to 5, where 5 is as high as you can go, you can see that in terms of the programs and services, in terms of decision support, end of life care planning, and in terms of spiritual support, participants say they are deeply satisfied with the program. Perhaps equally important, the bedrock for all this is trust. And the Care Navigators say that they are almost always able to establish a trusting relationship with the participants. They report a high sense of self-efficacy. They know that they can succeed in working with participants, and low stress. Fortunately, our pastors with whom we have engaged also report high satisfaction with the program. We know that they are the eyes and ears and the hearts of communities that we want to touch. And knowing that about them and about their satisfaction with the program is extremely important. Finally, there are the advanced care planning milestones. Let me say right here that the purpose of this program is to not talk people into deciding how they want to die one way or another. The purpose of this program is to empower people to think about how they want to live through that period of their life, to choose the care they want, document it, and get it. We know that African American patients are less likely to have their wishes respected. And this program is designed to help people think about what they want, say what they want, and get what they want. So this is extremely important. With the help of the Care Navigators, the entire program has worked on the development of a care planning workbook that is based specifically on the needs of the faith-based African American community. There's been leadership input from pastors and from leadership, and this workbook is now going into final graphic production, and we feel that it's a resource not just for individuals, not just for families, but for congregations and communities. The advanced care planning milestone completion demonstrates that individuals in this program more frequently complete advanced directives than African Americans do generally. The African community has been disadvantaged and again has disparities in this area, but 60% of the advanced care directives that have been discussed have been completed, and 39, essentially 40%, have post-completion since beginning the program. This is a systematic way of, again, empowering our participants to take control of their lives and of their time of transition. Before I conclude, I'd like to turn to Reverend Cynthia. Are there things that I overlooked that I should have shared here, Reverend Cynthia? There's so much that can be said. I want to make sure I communicated it fully. I think you're on mute, Reverend Cynthia.
I believe I am. Thank you for that. Dr. Jill, thank you. Wonderful job in really sharing some of the outcomes of this program. I don't have anything to add at this point, but thank you so very much.
Thank you.
I thank you to both of you for presenting such an important program and the many successes that you've had. What I would like to ask and for us to just talk about a little bit from and hear from Pastor Jones and Pastor Jacqueline, how has that affected your congregation? How did you become a part of this, and what were your hopes of what your congregants would get out of this? And I see the statistics here, but what is your experience of what has happened after your church being a part of this partnership or part of the program?
Pastor Jackie, you want to go first?
Sure. Good morning, good afternoon to everyone who is viewing from wherever you are. Thank you so much, Dr. Sloan, for having me. I am honored to be amongst this distinguished panel, especially with Reverend Cynthia, one of our own, who does such tremendous work. I actually inherited this program from my predecessor, but I believe what was at stake was really trying to get at ensuring our congregants were having conversations about end of life. In the African American community, particularly in theological and religious communities, there remains so much stigma attached to death and dying. And people feel that in order to fill out an advance directive or in order to have the difficult conversation, that somehow we are taking power and control away from God, or we're not exercising faith. And so as a result, you have a lot of members who don't begin to even consider the congregation until they're at a crisis point, or until they've been diagnosed with a terminal illness. And by then there's so many other stressors that are in place that it makes it difficult to really get to what the need of the person is, that trusted care that Reverend Cynthia talked about. And so I think the program has been so beneficial in demystifying conversations around death and dying, around challenging notions of theology that have permeated our congregations for a long time about what's right, what's wrong, how God feels, how God doesn't feel. No, how do you feel? And then around establishing relationships. I think the importance of Care Navigators has been so critical because it's a trusted relationship. It's generally somebody, even if you don't know them personally, they share your faith tradition most often. And so you know there's going to be some common ground. And so I think it's been good. We've had leaders who have been trained. There have been pastors throughout the city and the area who have been trained. And it really has assisted us in being able to refer members, because we also recognize that for many members, they want to have the conversation, but not necessarily with their pastor, because they may not feel they can be completely honest, or they don't want to believe to be wrong. And so they have a peer, they have a colleague, someone who has lived the experience that they can share with. And then for me personally, I have a mother who is living with dementia. She's 90 years old. And so I am a caregiver. And so our family is actually kind of going through this now. And so I've been blessed to kind of witness from afar and now experience up close the tremendous work that the ACCA program has been doing.
Thank you. Thank you so much for that. And I know, Pastor Jones, I know that part of your work focuses on mental health. And just in speaking to the outcomes of this program for your church and how it has blessed your congregants, can you weave in a little bit, how does that connect also with, how does this program connect also with some of your specific interests in mental health? How can it benefit that population as well?
You know, I noticed, and also I'm truly appreciative for being a part of this panel as well. And I echo all that Dr. Thompson had just shared. And I often think it was you in reading our bio mentioned our work specifically in the area of mental health and mental illness. And we're all well aware of the stigma that's associated with mental illness in the general population, but definitely within the African American community, and then specifically within the African American church. I recall seeing a question that was addressing that and asking that in the chat room. And so really appreciate the sensitivity and the level of awareness of the person who posted that question. And there's a parable in the scriptures. I'm a pastor, and so I'm gonna pull the text, and I need Reverend Cynthia to pull my coattail if I get a little long-winded. But there's a parable in the scriptures of Christ when he's teaching his disciples on how to value life, how to value individuals that have been either ostracized, stigmatized, or rejected by the common community. And he uses the parable of a shepherd who had 100 sheep. And then at the end of the day, he gathers his sheep and brings them back to the fold. And that's the picture metaphorically of a congregation, and metaphorically also of a community, that each individual sheep has value within our community. And so when he gathers the sheep back, he notices that one is missing. One sheep is missing. And so he makes sure that the 99 are taken care of. They're doing okay, but he recognizes, one passage of scripture says that sheep was lost. And what's very important is that the term does not refer to geographically, but it refers to disposition and exposure. That the sheep by itself, alone, without the support of the flock and the protection of the shepherd, will be devoured or destroyed or ruined by its condition, because there are predators that are there that their purpose is its demise. And so he then, he's not just satisfied with knowing 99 are okay, but he gathers the 99, and then he goes out with a disposition, I'm not coming back until I find that sheep. Once he finds it, he hoists it upon his shoulders, brings it back, and then he announces to everyone that sheep is now back home, and everyone rejoices. We relate as a flock in the African American community, and then the church in particular. On one perspective, we know that mental health, all roads, when you're addressing education, you're addressing medical issues, all roads intersect and intertwine as it relates to mental illness and mental health. And so what our goal is, whether it's a mental health challenge that's interwoven within now families and individuals who are living with advanced illness, or who are caring for persons with advanced illness, without the support, without the protection, without the comfort and the presence of the flock, it is our responsibility to make sure that we're not just comfortable in celebrating those that we can see, but also those that we can't see. And historically within the church, we have always had a practice or a term that we refer to as the sick and the shut in. Those who are sick, and because they are shut in, another, what can happen as a result of neglect is that they can become shut out, and they can become unseen. And so in many of our churches, we already, through our deacon family ministry plans, Sunday school ministries, age-based ministries, we have mechanisms to go out and to assure. This is one of the reasons why we became a part of this tremendous collaborative, is to not only keep them connected to us, but also to keep us connected to them. That although, and then this COVID-19 has taken it to a whole nother level as it relates to what could be catastrophic effects of isolation, and then dealing with the stresses of COVID, and then you add to that advanced illness, then you add to that how it affects mental wellness, not just of the persons needing care, but also those who are providing care, and then also those who are in loving relationships within, and then also how it affects the local congregation. We see the ACCAC as a vital link and conduit, not only to keep us connected again to them, and them connected to the faith community, connected to the compassion and the love of our caring God and Savior.
Thank you. Thank you so much for your comments and for that information and bridging the program with mental illness. You made some very important statements, truth and fact. Thank you so much. Can you talk a little bit about the pastors' roles and the faith leaders' roles in with the Care Navigators, or in this program? What is your role? How do you connect? And also, is this program specific to a specific denomination, or how is it broad for all faith communities, which it seems like it is? And is there a match? Someone asked the question, is there a match between the Navigators' faith and the patient or the client that they have? I said a whole lot there, so I can.
Well, we'll need you to help navigate us to make sure we address each one of those. Okay.
That was a whole lot. So first, the first question is, can you talk about your role in the program, in the ACCA program as a faith leader? What is your role? How, are you referring to the program, your congregants, or just what does that partnership look like? To be a part of 25 churches, I heard Dr. Jill say, well, what is that partnership? What do you do?
Let me mention this initially. When we first began, this is not, same thing with the program that I'm involved in called Mental Health Friendly Congregations. The intended purpose is not for it to be identified exclusively with any particular denomination or faith persuasion. So when the call went out in the very beginning, 7 years ago, a broad net was cast throughout Alameda County. It started in Alameda County. And for faith leaders / clergy, not just Christian faith leaders, not just pastors, but any individuals within our community, and not just African Americans. It was any individuals within the faith community or spiritual community, those are two different animals, that are providing care and services for African Americans within Alameda County. And so when the net was cast broadly, then there was a group of faith leaders, clergy, and pastors who then responded to that call. And those who then responded to their call, that became the genesis and the catalyst for the development of the Alameda County Care Alliance. And you'll notice that in the name, there was a lot of discussion that was made centering around because names not only define, but names can sometimes confine. Very important. Not only define, but they can confine. So we were very careful that although we are a faith-based organization, that the name that would be associated to this organization does not limit nor lock out any faith or non-faith in persons or organizations. Our primary concern is the holistic care of individuals within our congregations, in our communities. Thus, you have the Alameda County Care Alliance Collaborative. And that last C is what over the last year or so has been added to our name, to the name of our organization. Reverend Cynthia, you can elaborate more.
No, thank you, Pastor Jones, for taking us back to really that very first needs assessment that we held, and you're absolutely right. It was a broad net that was spread, frankly, throughout Northern California. We had our national partner, the Coalition to Transform Advanced Care, working very heavily with us at that stage. And the whole idea was literally for rabbis, Hindus, people of Filipino, Chinese, Jewish descent, all of this wonderful, quote unquote, melting pot that we have in Northern California, to be present, to have spiritual leaders present. We wanted to hear their voices. What do they see as the real needs that spiritual leaders find within the context of not only their congregations, but frankly, the broader net in their entire community? And we know of the respect, the incredible leadership that faith leaders have in our communities, and we needed to hear their voices. And Pastor Jackie, I know, had some wonderful thoughts that she wanted to share also.
Uh, I would add that I think the role of the faith leader or role of the pastor, it's multifaceted. I would say the first role is a bridge, because again, when you're dealing with a congregation and it's a new ministry or a new focus, a trust has to be established. And culturally speaking, people are more inclined to do something, participate in something, entertain something, if a trusted faith leader says, this is good for you, consider this, participate in this. In addition to that, I think the role of the faith leader is to really be a champion of the program and a champion of the work, and not just within the congregation, but even in the community. And in many ways, it brings validity to the program. And it also helps establish comfort with that theological base for those for whom faith is an important part of it. It is good for them to look and see that their leader is active and they're more inclined. And I also think pastors, because of the many ways that we interact with different families and different congregants, you're able to bring a perspective that perhaps is slightly different than what a healthcare professional would bring or what a social worker would bring, because we have a tendency, like many of them, to see families at their best moments, but also at their worst and most painful moments. And so you're able to help shape and bring expertise, if you will, area subject matter expertise to the program so that it's that much more effective and receptive within the community.
And if I may mention, there's a movie, Harriet, and there's a scene in the movie, a couple of scenes. One scene is outside of the big house, and the preacher is preaching. And the preacher is preaching, is what we call today code switch. He's preaching a text that was selectively chosen by the, I don't like using certain terms, by those who were enslaving Africans. And those scriptures were used for the purpose of further indoctrinating, and as Dr. Thompson was referring to, theologically justifying the institution of slavery and servitude. There comes there's a switch, and there's a scene when Harriet, she's made up her mind, I'm leaving, and she's going to aboard the Underground Railroad. And I think it was her father or her mother, I forget which one, said, go see the preacher. Go see the preacher. And when they told her that, she said, why would I go after what he's been preaching? Trust me, go see the preacher. And when she went to the church house, she went in, almost against her will, but because of her trust of her family, when she goes in, he opens the door on the floor of the church, and it's a respite, it's a place of protection. She had no idea that the preacher was also a conductor of the railroad. That's a picture of historically of the level of trust within the African-American community of the preacher. And now, as it relates to this particular area, I sometimes refer to it as the power of the mic. We are trusted. One scripture said we have to give an account for the souls of the saints. And so we value that relationship. They understand that value. And in light of the distrust of institutions, the voice, and when I think of the voice of the shepherd, is not just that person, but also that community that then bridges that divide for care.
And Doc, thank you for that, Pastor Jones. Dr. Danetta, if I could just piggyback on what Pastor Jackie and Pastor Jones were sharing. I think it's important to call out that some of the important work of this movement of the ACCAC, as you see, is very focused on people that are dealing with advanced illness, as well as their precious caregivers and the families of those individuals, but also dealing with this gap bridging the gap, as I spoke about earlier, with faith leaders and clinicians. I think if we're really honest with ourselves and we think about the shape, if you will, of the medical system presently, we have far too few African-American clinicians, physicians, nurses, social workers, incredible talent within our communities. What this movement also seeks to do is to highlight the incredible talent that we have within the faith-based community and the African-American faith-based community in this context, but also having clinicians and pastors interact in such a way where we really develop this mutual respect. We hear a lot about palliative care. The real work that we're doing is true person-centered palliative care work as we partner with health systems. So as you can see, we need all these incredible minds working together respectfully in ways that can benefit the folks that are dealing with advanced illness and the caregivers. If we don't have that collaborative, mutual respect and communication, then as individuals within the communities, frankly, they suffer. And so this movement is all about how can we build this true holistic approach, not only in the support services and empowerment of our participants, but also these respectful, collaborative, intertwined relationships and communications amongst physicians and pastors and clinicians as a whole. So it's tremendously important. I'm simply elated that we have this opportunity to share more about the depth and the work of this movement. And again, our idea is that this model that we've spent 7 years in developing, we want other communities to adapt that. And so we're going to be sharing at the end our contact information. We want to work with other regions and other communities across the country. So thank you once again for this opportunity. Dr. Jill, you might as a physician have some thoughts around some of the things that we've done working with clinicians to build this collaborative and mutual respect relationships, because both constituents are tremendously important.
And excuse me, I'm just going to break in just a second before you start talking, Dr. Jill, just to say, can you narrow it to a minute or so, because we do have questions coming in on the chat, and I would like to at least answer a couple of those in our last 5 minutes. Thank you.
Yes, I think I can say it very quickly. The collaboration with clinicians is vitally important and deeply important to them too. Clinicians care about their patients and are very aware of the need for a program such as this. We've brought clinicians and pastors together to share their deep compassion and their need for one another. So, and to promote communication there. Why don't I leave it at that, Dr. Sloan?
Thank you. Thank you so much. And I'm still Danetta. One thing I want to quickly for us to get to is someone asked, are there specific eligibility criteria that must be met to get into the program? How would someone get into the program?
I'm going to ask Dr. Jill if she would speak to that, and I'll certainly comment as well.
There we go, just trying to unmute. Absolutely. In general, we take people who have been referred by their pastors by a healthcare system. And what we need to know is that there are ways that we can support and help them. So we look across the 5 cornerstones: the spiritual needs, the social needs, the caregiving needs, the end-of-life needs, and try to identify, are there areas there where we can help? For example, a caregiver may hope that we could help their mother who has dementia. We're not medical caregivers. We can't work with that person, but we can work with a caregiver. We can work with a son or daughter who is so burdened and looking for support and looking for help. So we take people, I should also say, who are across the continuum of needs. Some people have relatively minor needs, and others, the need is much higher and heavier. But we never want to take people into the program that we can't help. For example, those with advanced dementia. And we don't want to take people into the program who just need a little bit of support. There's church resources and other community resources for them. In general, we focus on people who have a chronic illness where medicine is starting to fail. It's not the answer anymore. We need to look to total well-being.
Mm-hmm. Thank you for that. How someone else wants to know, how have the local healthcare systems responded to your efforts, and what lessons have you learned thus far about building collaboration with them?
I will respond to that question. How have local health systems responded? We are really very fortunate in the fact that this movement, as I shared earlier, is birthed and delivered from the community context. And so in doing so, our very first needs assessment that Pastor Jones and Pastor Jackie referred to earlier, we invited all health system partners within Northern California. So for us, that would be Kaiser Permanente, that would be the Sutter systems. We invited foundations, we invited Dignity Health, the California Healthcare Foundation. We even had a couple pharmaceutical entities that were present. This was a deep and wide net that was spread so that their voices could also participate in the conversation. We're really proud of the fact that Kaiser Permanente has been our core funder of this work since our inception. Kaiser Community Benefits has just been an incredibly amazing partner. We've also now working more deeply with Kaiser Operations. I'm thrilled about our new tech touching and enrolling participants over a 7-year, frankly, 6-year period of time. We had a year to build infrastructure and so forth, and then we literally launched our work in the past 6 years. We're having more deep conversations with Sutter currently, and it goes on and on. So we've been fortunate, but trust me, it's been a lot of work. You know, these things don't happen organically. And so we've been very fortunate to have this incredible group to support us, and we connect through our own relationships. The faith-based African American community is an incredible network of pastors and leaders. And so we leverage every opportunity and source that we have. And we're getting some really positive results from health systems and the fairly qualified health clinics. I should also add to that as well.
Thank you so much for that. And there are some more questions that we don't have enough time for. So I heard you say that your information will be available for people to be able to reach out and ask additional questions. I really appreciate each one of you joining us today. The conversation was really rich. I have so many more questions I would love to ask. You spoke a little bit about how you're funded. So someone did have a question about that as well. So please reach out to Reverend Perrilliat or Dr. Joseph or Pastors Thompson and Jones at the center. And everyone, thank you for joining the center. Matthew, is there anything I'm failing to say? Also, we will be doing on September the 30th, Reverend Perrilliat will be providing pastoral training on palliative care and advanced care planning. Please look for that information. It will be advertised on the center's website. Matthew, is there anything else I should say?
No, just a reminder that these sessions are recorded. You can find them on our YouTube channel. Just go to YouTube and search Practical Bioethics. And just before we sign off, I know that we have like 1 or 2 slides about the publications. Do we want to take a quick look at those?
That would be
flash them.
Sure.
Flash them.
perfect.
That really quick.
Can you flash your information as well? Is that?
I don't know if I've got that at my
Okay.
right at the moment, but we can send it out in a follow-up. So
Okay.
do we have any comments we want to make on these?
Yes, very quickly. This is our care planning workbook that has been developed through the support of our Care Navigator team, our pastors, our organization as a whole. We're really thrilled. It really talks about what Jill spoke about earlier, the thinking, the doing, and the documenting, the planning around advanced care planning. And so we will be sharing this more broadly very soon. And the next workbook you'll see focuses on our caregivers. Again, this is work that we've done within this many-year service work. We really want our caregivers to know that they're not alone. And this workbook really delves into self-care for the caregivers, but also the holistic approach to support and building a fellowship team for caregivers to assist them in their efforts. So thank you for showing those, Matthew.
Yeah, sure thing. And we'll send out a follow-up email with some contact information for people that want to follow up with any questions or comments. And thank you, everyone, for being on today. Thank you to our panelists and our moderator. We really
Thank you so much. Be well,
Thank you,
everyone.
Danetta.
Take good care.
everyone
Thank
be
you,
Yes.
everyone.
Thank you, everyone.
well and be safe.
Have a blessed day.
Take good care. Bye-bye.
Bye.